So when your patient first lands into the ICU from the cath lab and you've got your patient settled in, you want to start assessing your patient. First thing you want to do is kind of check the groin. Always want to check the groin to make sure that this Tui-Borst valve is locked tight, okay? If this is loose, you've now given freedom for the device to move. So you always want to make sure that this valve is tight, okay? And what is the number that it's locked at? So what is the number that the cath lab gave you? The cath lab said you're getting Mr. Jones and the Impella is locked in at 90 centimeters. You should verify the centimeter marking that it's locked tight at 90 centimeters. If it is loose and the device has traveled, it has migrated, you want to call for an echo as soon as possible and make sure that the physician doesn't leave because he may have to reposition this device. Okay, so we want to make sure that is tight. Echo should be in the protocol anyways as a baseline measurement. We want to see where the device is. We also want to make sure that we are angle matching. So the angle of insertion, most physicians come in at a 35-degree angle with their sticks, and we want to match that angle with the device. So the sheath should be sutured in place, and we should have a couple of 4x4s propping up the sheath to keep the angle that it's at. A couple tegaderms to hold it in place. Again, make sure that your locking mechanism is locked and your groin should be good to go. Okay. In terms of the console, if you're receiving your patient and you're in auto mode, auto is cath lab mode, and it lasts for 3 hours. After 3 hours, it will automatically take itself out of auto and put it in a P level. We'll go to P9. If you do get a suction alarm, the recommendation is to turn the flow rate down by 1 P level at a time until the suction is broken. Okay, so we're going to wait about 30 seconds or so until that suction is broken. Once that yellow banner has turned white, that means we've satisfied that alarm. The suction has now been broken. To get rid of this banner, we just push mute alarm and it'll go away. Okay, so this is what we're normally seeing on our patients for their Impella screens. This is normal waveform, and I always said if you have 2 humps here, you have a happy pump. So we have a pulsatile aortic waveform and a pulsatile motor current. Our placement signal is 108/78 with a map of 87. Again, this is not a true map because we can't zero the pump, so the recommendation is that you have an A line in place. If the pump were to go out of position, we're going to put the pump completely in the ventricle. So the pump has migrated from its normal position. Both inlet and outlet are now in one chamber, which gives us a ventricularized tracing. Notice that our motor current has dampened out. That tells us that the pump is completely in the ventricle. The console will alarm saying pump is completely in the ventricle, and you're going to follow the instructions on what to do. Okay. So we're going to go to our flow control. We're going to toggle down to P2. Okay, and we're going to reposition when imaging is available. Okay. You can also, if the physician's on site, you can use a repositioning guide. The physician can use a repositioning guide to reposition this without imaging. However, it is recommended that you get imaging and image the catheter as soon as possible. So once the pump is back in normal position, it's going to look like this. Excuse me. So we'll have 2 pulsatile waveforms. And then once we ramp up our flow control, we'll get our LV tracing back. LV tracing is only available at P4 and above. It didn't kick in. Sorry about that. There we go. So now our pump is in normal position. If the other scenario happens, our pump goes completely in the aorta. Our tracings are going to look like this. So again, we lose our motor current because now inlet and outlet are in the same chamber. Inlet and outlet are now in the aorta. So the tracing stays aortic-like. Again, we're going to follow the instructions on what to do. tells us exactly what to do. We're going to turn our flow control down to P2, and we're going to reposition with echo imaging when available. Just know that when you do turn your flow rates down, you may have to go up on support. You're really not supporting your patients anyways at this point, so anticipate that you're going to have to go up on your drips to support your patients at this point.